everyone. Thank you for joining us for what I hope will be an interesting and informative discussion around some of the latest data in rheumatology. My name is Professor Peter Nash from Griffith University, beautiful downtown Brisbane in Australia. And today we're very fortunate to be joined by Professor Laura Andreoli, who's an Associate Professor of Rheumatology at the University of Brescia. She's also a consultant at the Unit of Rheumatology and Clinical Immunology at ASST Spedali Civili in Brescia. It's a pleasure to have you with us today. And we're going to be discussing one of your recent papers published in Lancet Rheumatology. And it looks at a very topical and important issue, the outcomes of children born to mothers with autoimmune rheumatic diseases. It's the third part of a series in Lancet Rheumatology that's looking at pregnancy and rheumatic diseases. So welcome, Laura. Thank you so much for joining us.
Hello, thank you for this kind invitation. And I'm delighted to be here and discuss with you about our recent review paper, which is about one of the most frequently asked questions about patients of childbearing age who want to plan a pregnancy and have babies. So they actually want to know what's going to happen to their children and if their disease is going to have any impact on their health.
Thank you so much. So let's hear a little bit about yourself first. What kind of, tell us about your background a little and what you're working on in Brescia.
So I'm a rheumatologist, and I had the fortune in my career to work since the very beginning with Angela Tincani, who has developed a strong interest in pregnancy and reproductive issues in rheumatology since the 80s. So together with a gynecologist in Brescia, she set up a pregnancy clinic, and they managed women with autoimmune rheumatic diseases in a multidisciplinary way. So I joined the group nearly 20 years ago, and that's how I got in contact with the unmet needs of patients. And that's how we based our research on developing answers to these questions. And we were lucky in our hospital to get collaboration from colleagues like a child neuropsychiatrist. And this is actually reflected in the composition of the authorship of the review paper. So you will see that we have gathered many different specialists who are useful and helpful to interpret data and to give balanced answers to patients.
Excellent. So what was the objectives of this particular paper and what were the methods? How did you do it?
So we basically started with brainstorming. So altogether, we tried to identify the most important topics, and having a patient representative in the team was instrumental to identify those topics that are of utmost importance to patients. So we went through our clinical experience. We discussed with the patient representative what was the list of the most important questions. And so then we started collecting the literature. It was not a systematic literature review, but still I would say that we managed to include the most important papers over the decades, because it's actually been not a huge area of investigation. So yeah, meaningful papers are not many. So which is actually a drawback if we think that it's not possible to answer in an evidence-based manner to many of the questions that patients pose to us.
So let's go through the paper. You've divided it into antenatal and early postnatal life. Is that a cutoff of 3 months, 6 months? What's the cutoff for the postnatal life?
Well, I would say 1 year of life because most of the literature, which has been prompted by the use of biologic agents during pregnancy, so there has been a focus in the past 10 years on the rate of serious infections in the first year of life in children who had been exposed to biologics during pregnancy. So I think that's an important timeline, but there is a trend in general in pediatrics to consider as very important the first 3 years of life. So they call it the 1000 days, the first 1000 days. And yeah, it's a very complex area of research. And it's even more difficult with regard to rheumatology because we deal with rare diseases or low prevalence diseases. And it's not that easy to conduct this kind of research because you need a multidisciplinary team. And this is something that cannot be achieved in any place. So it's a very special area. And yeah, we collect data, but we aren't sure how about the generalizability of these results because they are conducted in selected populations in selected countries. So yeah, definitely we need more research in this field.
Excellent. So we'll turn to the effects of maternal disease factors. Do you think, from your reading and your experience, that there are long-term effects, and I mean through to puberty and adulthood, of some of the diseases and the therapies, or do you think the problems will show themselves in that first 1,000 days?
Yeah, thanks for this very interesting question, which is actually something not easy to assess because whenever we want to study children who are in their teenage years or in early adulthood, we need to adjust for many possible confounders. Which actually would require larger populations than those which have been studied so far. So here, really, we need to have a honest conversation with our patients and tell them that we cannot be 100% reassuring about the lack of any impact of maternal disease on the long-term outcomes. But still, we can clearly say what we know and what we don't know. So it's important to clarify and to explain what the knowledge is currently. And yeah, the informed patient will take an informed decision regarding their family planning. I think that it's important to keep in mind that risk perception is highly variable across individuals. So, whenever we speak about possible effects on the offspring, then I mean, patients could react in a different way. The important point for us as clinicians is to provide clear and updated information.
So what about the effects of various autoimmune rheumatic diseases on pregnancy itself? We know lupus and SSA antibodies and antiphospholipid, but what about all the others? Rheumatoid, psoriatic, AS, scleroderma, vasculitis. Can you tell us a little bit about the effects on the pregnancy from autoimmune rheumatic diseases?
Yes, this is a topic that we know better, that has been a lot of research. And we can say that there is a transversal effect across diseases. So systemic inflammation, which occurs in active diseases, so whatever disease you are thinking about, so chronic arthritis or connective tissue disorders. So there is this common thread that systemic inflammation is able to affect placental development, which in turn leads to poorer fetal development. And so that's why we see an increased frequency of small for gestational age babies, premature deliveries in women with autoimmune diseases. So we see many different effects, and we can actually try to prevent these unwanted effects by treating active disease during pregnancy. But I would say to let women enter pregnancy in a disease state of remission, or if not possible, low disease activity. And so in order to achieve this goal, we need to use medications. And fortunately enough, most of the anti-rheumatic drugs that we use are compatible with pregnancy. So there are very few that are harmful, and rheumatologists know them well. So we need to apply the treat to target strategy, as we do in non-pregnant people, also during pregnancy. And by this way, we are probably going to prevent many of the adverse effects that we see in the literature from the last decades, when women had an increased risk of flares during pregnancy, or they started pregnancy when they were not under stable control.
So, Laura, what genetic information can you pass on? And many of the autoimmune rheumatic diseases spread with high genetic penetrance.
So what we say about the familiar aggregation of autoimmune rheumatic diseases is that the transmission is not direct like in other genetic disorders. So it's not 100% chance that the baby will get the same disease as the mother or another autoimmune disease. But the reassuring message is that women living with rheumatic diseases, they know symptoms very well. And whenever they might see those signs and symptoms in their children or young adults, offspring, then they actually might refer them early to a rheumatologist. And we know that early diagnosis is the situation that provides the best prognosis nowadays. So it's important to let patients understand that they are not alone, and even if something happens to their children, then rheumatologists can be of help. And of course, this question is a very important one. So there have been studies, surveys across patients' populations. And the, let's say, epidemiology data tell us that such risk of developing autoimmune disorders does not seem that high. So we really need to learn more about this and to keep in mind that environmental factors are important in eliciting the genetic background. So we cannot make any prediction in a very precise way.
So you mentioned that disease activity is very important effect on outcomes. Are there any other important background factors like race, socioeconomic status? What are the background issues that affect outcome?
Thanks for bringing this up. This is actually a topic that we developed in the review, and we made a nice figure that summarizes all these aspects. So all of us live in a society with environmental effects, and it's difficult to assess the impact of these factors, but still there is an effect. So we need to take into account all the possible factors and suggest to women who are planning a pregnancy to live as healthy as they can. So there are very well-known risk factors such as cigarette smoking, alcohol use, which may be corrected before pregnancy.
Yeah.
So there is room for counseling.
It is a very nice, it is a very nice graphic. I was interested to see that you included microbiome, which is potentially adjustable. And I was interested in what evidence there is that the microbiome affects outcomes. And you also mentioned pollution and contaminants. And there's been a couple of recent papers, one in recent clinical experimental rheumatology, talking about rheumatic diseases as a result of pollution and contaminants. So I'm just curious if there's evidence that microbiome or changing it can affect the outcomes, and if there's any work being done on pollution and contaminants.
Well, as far as I know, this kind of research has been ongoing in non-pregnant people with autoimmune rheumatic diseases, but definitely next step will be to study this in pregnant people. And together with Professor Maurizio Cutolo from Genoa in Italy and Professor Caroline Ospelt in Zurich in Switzerland, we have set up a study to investigate epigenetics during pregnancy in patients with rheumatoid arthritis and systemic lupus erythematosus. So the results are now under elaboration, but it will be really interesting to see how the environment, as you mentioned, pollution and the socioeconomic status, so the way you live actually adds on your genetic background, which is prone to autoimmunity, and then the environment adds on through epigenetics. So I'm much looking forward to the results of this study.
I think the controls in that study would be very pivotal to know what you're comparing to.
Yeah,
now
exactly.
You mentioned phospholipid antibodies, you mentioned SSA and SSB. Are there any other sort of routine tests you do on every pregnant rheumatic patient?
Well, definitely patients with rheumatic diseases must undergo all the examinations that pertain the general obstetric population. So, for instance, thyroid function is very important because we see a higher frequency of thyroid dysfunction, especially hypothyroidism in women with autoimmune diseases. And another important topic is vaccinations. So we need to assess whether women are covered against major infections, which might negatively affect pregnancy outcomes. And if they do not have any protection, well, we should think about getting them vaccinated prior to pregnancy. So I think there are different items that we need to check preconceptionally.
Are any vaxes that the rheumatologist always forget? I mean, rubella and the usual pregnancy ones, but are there ones that we forget about that pregnancy might benefit from?
Yes, the general vaccinations that are recommended to pregnant women. So I'm thinking about influenza vaccination during the period when it is recommended. I'm thinking about the vaccination against pertussis. So it's recommended at the beginning of the third trimester so that the mother can build a new response towards this booster and then provide passive immunization to the fetus. So all these vaccinations are not contraindicated in women taking immunosuppressive drugs.
I wonder what the recommendation is for COVID vaccine now during pregnancy, before pregnancy, booster shots. Do you know the latest on COVID recommendation?
It is recommended in pregnant people, and there is not much evidence in women with rheumatic diseases. We managed to collect some data from the COVID study, which was a large survey conducted during the pandemic. And actually, the impression is that COVID vaccination during pregnancy does not significantly alter disease activity, does not induce severe flares, which is actually good because the expected benefits are much higher because the baby will be born with passive immunity against COVID.
And let's talk about medications. Is there anything new, different that you can update us with? I know there's a EULAR recommendation for managing pregnancy and lactation recently published, which would be quite helpful as a guideline or a recommendation. Anything we should be aware of? JAK inhibitors in pregnancy, some of the newer 17 inhibitors, 23 inhibitors. We know about TNFs and certolizumab. We know about hydroxychloroquine, azathioprine. We'll talk about steroids separately, particularly what dose and how to manage a flare. But is there any updated information on some of the newer drugs that we're now using a lot?
Thanks for this question. Yeah, the meaning of updating the EULAR points to consider is actually to review the literature around newer drugs and provide recommendations. So you mentioned JAK inhibitors, which are drugs with little evidence. So the recommendation is still to avoid them during pregnancy, but not because there is evidence of harm. It's just because we don't have enough data up to now. And regarding biologics, well, here we need to consider that biologics are protein, large molecules. So with regard to the first trimester, there is probably no impact on the developing fetus. So they are probably safe with regard to malformations, risk of miscarriage. But still, there is no strong evidence yet for newer biologics, so the recommendation is to stop them at the beginning of pregnancy. So you might use them up to conception and then stop them, which is actually probably not the best solution for women. So the recommendation is to, as I said, to apply the treat to target strategy. So I would rather have a woman during preconception counseling having a treatment with a compatible drug, or let's say with a drug that has enough evidence. But the other way around, it's important to counsel women with inadvertent exposure to drugs as well. So if any pregnancy starts on newer drugs, we can reassure the woman that probably it's not a problem. So the pregnancy itself doesn't need to be terminated.
That's a very important issue, because these days I see more accidental pregnancies while taking methotrexate, while taking leflunomide, while on a biologic. And then the question is what to do about those pregnancies other than to stop the medication and hope they don't flare. Is there any new advice on what to do in someone on methotrexate or on leflunomide?
Methotrexate is still recognized as a teratogen. So it's probably not that common to have major malformation if the drug is stopped as soon as the woman recognizes to be pregnant. But still, there is a need for a multidisciplinary management and to counsel this woman towards the risks so that she can take an informed decision. Regarding leflunomide, is not recognized as a human teratogen anymore, but still the evidence of use during pregnancy is too little to recommend this in clinical practice. So right now, the recommendation is either to stop leflunomide a few months before conception in order to allow a washout, or in the case of unintended pregnancy, we can go for the washout with cholestyramine as we did in the past. So that's always a good option.
And if the patient flares in pregnancy and we need to use corticosteroids to settle them down, is there a dose sort of limit that you try to use if you can? People talk about 7.5, not crossing the placenta, higher doses does. What's your feeling about managing flares in pregnancy and steroid and dose?
Well, here I'd like to be provocative and say that we should avoid flares during pregnancy. So the aim of preconception counseling is actually to set up a treat to target strategy that would prevent any flares. But of course, they happen. So corticosteroids are the prompt tool that we can use. And we can use it in intravenous pulses. And then, I mean, you just use whatever you need, the dosage that you require to manage severe flares or even life-threatening conditions. And then if we speak about prednisone or prednisolone, we must keep in mind that the majority of these drug will be inactivated by the 17-hydroxylase in the placenta. So the exposure of the baby, of the fetus, will be minimal. But we know that corticosteroids are a double-edged sword, even in pregnant patients. So we need to provide an immunosuppressant in order to taper steroids as soon as possible. So pregnancy is really a time-sensitive situation, so we cannot really afford to have a woman on high-dose steroids throughout pregnancy, because otherwise both maternal and fetal adverse effects will be unacceptable.
Okay, you've got a section in your paper on the long-term effects of antenatal exposure to maternal medications. Do any spring to mind? Do any of our drugs have evidence that they cause long-term effects on the fetus and the baby and the growing child?
Well, the literature so far doesn't show any strong evidence for long-term effects. I must say that papers looking at these issues were very few, but so far no evidence that might be of concern. I think the main message is that we need to keep collecting data and investigating these aspects.
You've got a very nice section on frequently asked questions, some of which we've discussed. Will the disease affect my unborn child? Clearly, that must be a very common question. Will my medications affect my unborn child? We've talked about that. Am I ready to have a baby? You very clearly told us about keeping disease activity under control. Should I shelter my baby during the first year of life because of increased risk of serious infection? What's your feeling about that particular question?
Well, this is a question mostly related to biologics and especially exposure during the third trimester. So here we need to differentiate biologics upon their rate of transplacental passage. And this is a point that has been enhanced in the last EULAR points to consider. So I think it's always a risk-benefit assessment in the individual situation. So if the baby has been exposed to drugs which are IgG and cross the placenta, and the fetus actually gets much higher concentrations of IgG than maternal ones during the third trimester. So this baby will be born with high concentrations of the drug. So while we wait for the clearance of maternal drug, probably this baby needs to be monitored a little bit more than other babies. But still, the literature is reassuring towards the lack of significantly increased risk of severe infections. So this is an important reassuring point.
Excellent. Then you say, should I refrain from getting my baby vaccinated?
Absolutely not. Vaccinations are a major achievement of modern medicine. And luckily enough, the vaccination schedule in most countries do not include live vaccines in the first 6 months of life. So the only vaccines that we need to watch out for are rotavirus and BCG vaccination. So rotavirus right now can be suggested to even to babies who were exposed during pregnancy to TNF inhibitors. we've got reassuring data from gastroenterology. There is still a caveat on BCG, and we all know about those case reports of disseminated tuberculosis in babies exposed during pregnancy to infliximab. So right now, the recommendation is to hold the BCG vaccination during the first 6 months of life in those children exposed to IgG monoclonals, so those who which cross the placenta. So this is very important to know in those countries which still recommend BCG vaccination at birth.
We've talked a little bit about passing the disease on to my child, but a very interesting section here about, will my child be more likely to develop neurodevelopmental disorders? And I was unaware the literature shows an increased risk of autism spectrum disorder, attention deficit hyperactivity, learning difficulties, etc., in children born to women with autoimmune rheumatic diseases. That's a neglected area, I suspect.
I agree. It's neglected mostly because it's a very difficult area. It's a multifactorial area. So the link between maternal autoimmune disease and neurodevelopmental issues in the offspring started back in the 80s. Regarding research in autism spectrum disorders, there has been a research trajectory showing that maternal inflammation might be one of the predisposing factors. So that paired very well with maternal inflammation in rheumatic diseases. But if you turn the issue the other way around, we might say that the epidemiological evidence that we have right now might be influenced by confounders. So if you use administrative data to assess the prevalence of these disorders in the offspring of mothers with rheumatic diseases, you might claim that these mothers, they're more careful towards their children's problems, so they might refer their children to neuropsychiatrists more often, and this comes out in more diagnosis. So this is a possible explanation. But another point that we made in the review paper is that increased risk doesn't always correspond to a high risk. So it means that if you have an odds ratio of 2, but the condition is rare or low prevalence in the general population, then you will end up with not a huge number of affected children. So it's important to address these concepts to mothers, to future mothers, because sometimes they get scared by news, by a sort of, I would say, general interpretation of scientific data. So it's good to explain each study one by one.
Yeah, I think it's a very important area that needs future work. The other thing that I couldn't see a lot about is males. What about the father taking medication, having autoimmune disease, particularly medication, any impact on the baby from what the father is taking?
Yeah, thanks for raising this issue. Male fertility and reproduction in rheumatology has been neglected for many decades, but now we know more. There's more attention. And we know that the majority of anti-rheumatic drugs do not have an impact on sperm quality. And we even know now that methotrexate doesn't need to be discontinued before conception. So it's really important to learn more about paternal exposure because it may turn out that some precautionary measures that we took in the past are not needed anymore. And this will, of course, ease the management of men living with rheumatic diseases.
Okay, so that's very reassuring. So thank you very much. Any take-home message you want to tell the clinician talking to pregnant women and women planning pregnancy every day? Any take-home message?
Well, the take-home message is that nowadays we can consider reproductive rheumatology as a sort of subspecialty, and family planning is important to the quality of life of people living with chronic conditions. So rheumatologists cannot really say anymore that it's not their business. So pregnancy, although it needs to be followed up in a multidisciplinary fashion, but in the team, there must be a rheumatologist. And of course, part of the counseling should be done by a rheumatologist. I think of drugs, for instance. We cannot expect gynecologists to be able to run proper counseling around anti-rheumatic drugs. So it's important to work in team. It's important to listen to patients because they are definitely a good source of research questions that we need to address, and to work together with patients' associations because they really have the power of coagulating big numbers of patients so that we can run surveys, questionnaires, and collect much more meaningful information that we can do as a physician using administrative data or registered data.
So thank you very much for your time today, Laura. We should get people in good disease control, multidisciplinary team if it's available, perhaps put all the pregnancies into a registry and just record what drugs they're on and what the outcomes are like. Use the EULAR guidelines. I learned to make sure I check the thyroid function, get our patients vaccinated to the appropriate thing. So, and reassurance about the medication and about the male fertility. So if you'd like to know more about this paper and others uploaded to the Immune-Mediated Inflammatory Diseases Forum website, you can get detailed slide sets and more available at imidforum.com. Please subscribe to this podcast on Spotify, iTunes, or other podcast media. Let us know what you think. You can also watch us on the IMID Forum on YouTube. And finally, you can follow us on Twitter, LinkedIn, and Facebook to keep up with all the latest data in immune-mediated inflammatory diseases coming soon in 2024. Thank you so much, Laura.
Thank you for this nice conversation.